Our next presenter is, once again, Dr. Jonathan KATZ, and since I've already introduced him, I think I'll just step aside and let him give his presentation on understanding a neurologist's approach to the diagnosis and treatment of peripheral neuropathy. Dr. KATZ.
Thanks. Is everybody having fun so far? All right. So we'll just continue from last time. So this is my own time. I think I'm going to do like a little weaving here. Like I don't think these slides are 100% in an order that makes sense, nor do I think you can actually put them in an order that makes sense, because when I think about this stuff, I don't think it makes sense to me a lot of the time. But one of the things that we were kind of alluding to, it's kind of like the elephant in the room, is, you know, I don't even know if I get into it as the talk goes on, but I'm going to say it anyway. But like neuropathy is like an incredibly hard field to do. It's on the one hand, it's extremely easy, and on the other hand, it's extremely hard. It's extremely easy because, like, a lot of the times it's not so hard to recognize. Somebody comes in and says, "Hey, doc, I got numb feet," and you're like, "Okay, you have a neuropathy." But that's like really simple. It's not really that hard. On the other side, you got people coming in with these autoimmune diseases. You got people coming in, and you're going to say to them, "You've got a neuropathy. It's idiopathic. Like, I can't tell you exactly what's causing it." But on the other hand, you got like these rare diseases, and you got to be able to differentiate one from the other. And then at the other side of it all, you have like IVIG, which costs a fortune, and the insurance companies don't want you to do it. And is there anybody from an insurance company here? Right. Good, so I could talk behind their backs as much as I want, which is a beautiful thing. They're never here, and it actually says something like, where are the insurance companies? Like, I'm not even saying this to be funny. Like, do they not have to learn? Like, are they able to review your neuropathy opinion and never once in 100 years show up at a meeting to learn anything or ask what the heck is going on? These are $10,000 drugs, so a month or a day. So they don't want you to use these drugs. Now, the other group that I would point to a little bit is it's ourselves, like the neuropathy doctors. You can go to a neurologist. Is anybody here from like Lompoc? So there actually is a person from Lompoc. I always use Lompoc as my example because I have no idea where it is. The word Lompoc just sounds funny to me. Like, who named the town Lompoc? Like, did somebody actually do that? It must have been somebody's last name who came over from like Czechoslovakia. It would take a wild guess. And they named it that, and there must be a doctor there. And I don't know how that person could know very much about neuropathy. And then I fear it's very far from everywhere. So it's a really hard field, and who knows who you're gonna go to? So I saw the movie did anybody see the movie about what's it called? Where the housing market completely bursts, and the guy tells you the story. It's really same guy, The Big Short, the same guy. So The Big Short, I love that movie for two reasons. One is it was just a good movie, but two, one of the characters, the guy, Dr. Burry, was my resident, so I knew him really well, and he quit our program. And he says to me, he actually quit the day that my younger daughter was born. So I saw him like in the middle of the night as I'm walking around the hospital. And he tells me that night he's quitting. I was like, are you kidding? Like, you're 3/4 of your way through your neurology training. What could be better? And of course the guy goes out and like figures out the housing market's going to burst and becomes a billionaire. So that was one of my misdiagnoses in life, but so be it. And then on the other hand, you have like, the other guy in that Steve Carell played. This is Los Angeles, so you could talk about movies and get away with it. But Steve Carell, that guy, his name was Steve Bauman in the movie, but his real name is Steve Eisman. And that guy and I went to camp together, and we were in the same bunk for about 5 years. So I know him really well also. So it was a really fun movie to watch. And it turns out that, why am I talking about this movie? Because that movie, if you stop and think about it, it was about like everybody's individual incentives were to just sell houses. And there was no checks and balances on the system whatsoever. And at the end, the system completely blows up. So anybody watching that's going to try to figure out who to assign blame to. The Republicans are going to blame the Democrats. Dominic's going to blame the Democrats. The Democrats are going to blame the Republicans. The bankers are going to blame the people. The people are going to blame the bankers. Really not a good way to go about a system improvement with everybody just blaming each other. It's not a good way to go forward. But what that tells you is systems really do develop where everybody has individual incentives that don't make any sense. I would argue that when you have a field with really difficult diagnosis, one therapy that costs $10,000, IVIG, another therapy, Rituxan, very expensive. You got industry involved. You got people who stand to make a lot of money. On the other side, you got a therapy, prednisone, basically free, costs like a nickel. Insurance companies don't want you to use IVIG. They want you to either use prednisone or suffer. They don't come to meetings because they have nothing to gain from it. You have the exact same system going on with neuropathy. There's no difference with a system where people have a lot of incentives, there's a lot of money involved, and people can't get together and try to figure out how to do the right thing. So you have a lot of misdiagnosis on one hand, you have a lot of blocking of correct diagnosis on the other hand, and it just gets to be like a weird mismatch of a very nonsensical, bizarre thing. So one day I'm going to try to talk to the guy who wrote The Big Short and see if he could write a book about neuropathy. But it really is a really hard, interesting field, so we'll talk about it. On the one hand, it's really simple. What do you need to know to diagnose neuropathy? Like, you could sit with a patient and you could basically take a history in 10 minutes if you kind of know the field and just ask a few questions, and you guys should all have good answers. So the first question is, what's the timing? When did your feet go numb? When did you start getting weak? Was it very quickly? Was it over a week? Was it over 3 months? Was it over a year? Has it just been very gradual over a decade? That gives you a lot of clue about the diagnosis. Secondly, location. Where in your body is it? Is it your feet? Is it your arms? Is it your trunk? Like, where is this happening in your body? Another big clue. What types of nerves are involved? We went over that in the last talk. Are you getting numb? Are you getting weak? Are you getting autonomic symptoms? And then, are other diseases present? Are you diabetic? Do you have a bad B12 deficiency? Have you had chemotherapy? So those sorts of things. And then you look at some nerve conduction studies, and these things just break down. Like, I could tell you, from the results, like, pretty much what you have from answering just those questions. It's not really that hard to do. And then sometimes you have to know other things, which we'll touch base on later. But it's not so simple. It's really hard, because if you think about it, there's many different ways neuropathy could present, and I'm going to show you a slide on that later. We don't have a test. Like, there's really just about no test that says you have this. So you're in there talking to your doctor, and you better trust what they have to say if you're going to believe in the therapies and whatever. You have to have a pretty good sense of what's going on, because somebody's going to tell you a word for what kind of neuropathy you have. It's probably not going to mean a lot to you. So to go forward, you have to have a pretty good sense to it. It's also hard because it actually, I'll show you again, but the doctors don't know this field very well. Like, I've talked to the American Academy of Neurology. I've reviewed cases for insurance companies. I'm on the advisory boards of about 10 different companies. We started a doctor's website. It's a really hard field. Like, that's the little secret. Like, people don't know this field. There's really probably 100, 150 people in the world who really get this. And you don't see those people in Lompoc very often. So where is Lompoc, for crying out loud? Is it near, where's Santa Maria? So anyway, idiopathic is another big thing. Like, somebody's going to tell you it's idiopathic. You just have to trust that it's just like part of your body. That's what it is. We don't get a lot of data. Like, somebody, well, not somebody, the last talk mentioned a registry. It's important to get, like, what's happening to people. We don't really have a way to put all these pieces together. And then we already talked about it. IVIG is really costly, so insurance companies get involved. If you work in a medical office, there's a lot of chaos. You're getting calls all day. You can't do this. You can't do that. I haven't been lately. People have been turning down prescriptions for amitriptyline, which is like an 80-year-old $1 drug for Lord knows what reason. So it's just getting really weird. Why does it get so complicated? Because even though I say to you, you need to tell me where the neuropathy started, there's like 100 different answers. You need to tell me what fibers are involved. Like, it could be just in your motor fibers, just in your sensory fibers, or both. It could be affecting your shoulders, your hands. It could be in one shoulder or both shoulders. It could be multifocal, meaning you're just picking off one nerve, or it could be generalized, you're picking off nerves all over the body. Sometimes weird regional presentations where just an arm is involved or whatever. Then it could be acute or chronic. It could be painful, numb feet, or it could be painless numb feet. They actually both imply completely different things. And then I could give you IVIG, I could give you prednisone, you could have a family history, no family history. We do nerve conduction studies, they're hard to interpret. Then a bunch of blood tests, also hard to interpret, like your B12's a little low, does that mean anything, does it not mean anything? If you start getting into it, you know, you got like 50,000 ways to answer these questions, so there's like 50,000 different ways people are gonna come into your office with symptoms, and it gets really hard to say, you know, symptom complex number 23,000 is a certain diagnosis. You know what I'm saying? Like, so invariably, people are going to come into your office with like myriad different clinical presentations, and it can start getting really hard. So you got your reasoning process, which can get really out of hand, and then where along you start thinking about the disease. So you do nerve conduction studies. Is the problem like showing up near your wrists? Is it showing up near your spine? Is it throughout the whole nerve? Whatever. So there's like a lot of different ways. And if you look at like a doctor's website on this, people are like, get all these confusing diagnoses. They don't know what to do. The other part is you're dealing with people, and like we said earlier, people get symptoms for a lot of different reasons. It's not only neuropathy. So not the easiest field in the world, but there's some things you should know, and I'm just going to kind of go through it about reasoning in neurology. So numb feet, the most common presentation of neuropathy by far. It's what diabetic neuropathy shows up as, and it's what idiopathic neuropathy, the most common neuropathies, show up as. So 80% of your people are going to be coming with numb feet. These cases tend not to get referred to universities. They tend to be the ones that are dealing with foot pain, that whole first part of the talk, like the good question that got asked earlier. And when you are coming into my office with numb feet, the odds are I'm not going to find a specific diagnosis. You're not going to be diabetic if you're coming to my office because somebody would have figured that out already. Like, I'm not going to be like, surprise, you're diabetic. Like, that almost never happens. It actually has never happened. It's usually going to be they're already diabetic and they're getting a neuropathy, so I know that they're diabetic, or they're not diabetic. So if you come in and you're trying to like get diagnostic information and your diagnosis is numb feet, there are only extremely rare cases where I'm going to, at the end of the workup, tell you I found something. Usually the story is going to be right there at the beginning, and it's not going to be something treatable. So that's the bottom line with numb feet, and we're going to be managing symptoms or talking about prognosis, and that's just the way it goes. Doctors will order tests in these cases, and I think it's reasonable to order a few tests. There's an association with numb feet with glucose intolerance. So do you guys all know about that? Like, you go in, you're like, doc, my feet are numb. They run 1 million blood tests. They don't really find anything. So they order this thing called the glucose tolerance test. It's questionable whether this really helps, though, because what if I tell you you have a glucose intolerance? Like, if you drink a ton of sugar, 2 hours later your blood sugar is a little high. What's that really going to tell you in the big picture? It's going to tell you to kind of watch yourself a little bit. But you know what? We should all be pretty much watching ourselves anyway. So it's not really that shocking information. Gluten was a big issue a few years ago. It turned out not to be any much. It turned out to not be a giant part of neuropathy. Statins, not a big part of neuropathy. So again, with numb feet, the bottom line is you'll get a B12 test, probably not a big issue. So the bottom line is if you have numb feet, probably not going to find anything. At the other end of the spectrum is this thing called CIDP, chronic inflammatory demyelinating polyneuropathy. Now these cases present to the doctor completely differently than a numb feet. If you're walking into the doctor's office with numb feet, it's probably not going to be one of these immune neuropathies. The immune neuropathies, like if you take the textbook case, and I'll show you a few of these, the textbook case of CIDP is somebody who comes in with a gradual onset, usually 3-6 months since the disease started, usually not 2 years, or they're not going to go, I had symptoms 10 years ago. They're not going to be going, my feet are burning. And when you examine them, they tend to be a little bit weak everywhere. Their hips, their shoulders, their hands, their ankles. Their feet are beginning to go numb. They have no reflexes, and they kind of say, I'm just slowly getting worse over the last 6 months. And then you take them into a nerve conduction lab, and I'm not going to kind of like teach you nerve conduction studies right now, but you take them into a nerve conduction lab, and you see this thing called conduction slowing, like everything's conducting a little too slow. Like a nerve conduction velocity is supposed to be 50 meters per second in your arms. Somebody with CIDP, you're going to see 30-something meters per second. And in your legs, there's electricity is supposed to conduct at 40 meters per second. You take them in, maybe you'll see 25 meters per second. These are rough estimates, but that's called demyelination. Their nerves aren't conducting electricity fast enough, and you get a clue that you're looking at CIDP, and you go ahead and treat them. It's a pretty rare disease, though. It's about 1/30th or 1/100th as common as your numb feet presentation. And there's been great clinical trials on this side of the equation, on the immune side of the equation, because the treatments stand to be fairly profitable, so the big trials happen. And we know for sure that IVIG is a great therapy for CIDP. And when somebody clearly has it, it's a great therapy. But like I said earlier when I was giving you guys my, analogy, that cost issues are gigantic in CIDP, and you could treat it with either IVIG or prednisone. And they're both very effective therapies, and I think patients should be open to both of them if you have one of these conditions, because prednisone can be very manageable and very effective, and IVIG can be very effective. IVIG has clearly become the first-line therapy for the treatment, and insurance companies are generally willing to give it if you can prove to somebody that the case has CIDP. So what is the reason we use IVIG? If you look at the literature, prednisone might work a little bit better, like just on flat out, like how well is it going to make the neuropathy go away. Prednisone, the numbers in the few studies that have been done for responsiveness are a little higher. The IVIG numbers are really only about 50%, so I only give it 2 pluses out of 4, whereas prednisone I give corticosteroids, prednisone is a corticosteroid, I give 3 pluses out of 4. For adverse effects, like how bad are the side effects, IVIG really, it doesn't have a lot of side effects. Like it could give you aching, it could give you flu-like symptoms, it can make you kind of feel bad after you get the infusion for a few days. There's some horrible things that could happen with IVIG, like blood clots, but they're extremely rare, so we don't worry a giant amount about them. Prednisone in the short run, it's a steroid, and it makes you fat, and it makes you get acne, and it makes you get bruising, and it gives you heartburn, and it makes it hard to sleep. But in the short run, it's not that bad. The real bad side effects of prednisone, like getting really fat, getting moon-faced, if you keep people on it at a high dose for too long, infections, it's going to be a big problem. But in the very short run, like if I had to say to you, you're going to take prednisone for a month and a half, there's some pros to it. Like it's kind of easy to give. Like you don't have to have an infusion. Nobody has to come to your house to take a pill every morning. So it's not 100% in the short term which one I'd vote for. For long-term adverse effects, prednisone's a mess. And if you're going to get started up a road where you need therapy a long time, you don't want to be taking prednisone forever. And IVIG, it's pretty easy to use, and if you deal with it well your first infusion, you're probably going to deal with it well at a lot of subsequent infusions. But the big issue is in cost, and we kind of alluded to that earlier. And this is why you get into a dilemma. The insurance companies don't want you to give IVIG to somebody if you don't really know what the diagnosis is. Problem is, misdiagnosis is so rampant that even when doctors really do know what the diagnosis is, the insurance companies remain in hassle mode, and we don't have a really easy system to figure out which doctor knows what they're talking about and which doctor doesn't. So it ends up being a giant jungle. Prednisone, if you start it, it's not even going to get reviewed, so it's got a little bit of efficiency that way. Now here's where it gets confusing. CIDP is not the only autoimmune neuropathy, and people have started to use this alphabet soup to name other types of autoimmune neuropathy. So MAD-SAM, which is also called Lewis-Sumner syndrome. The Lewis part, hint, hint, is one of the very good doctors here in Los Angeles, so if you want to make a note about that. But MAD-SAM, multifocal acquired demyelinating sensory and motor neuropathy, is a condition that is an autoimmune disease, but it doesn't present like classic CIDP. You start picking off nerves. So you get weak in your left hand, then you get weak in your right hand, then you get weak in your leg. Or it takes this totally random course through your body. And what's happening here is instead of getting a rash over your whole nervous system, it's like a rash pops up in one spot and then another and then another. So you're developing multiple lesions of your nerves, and that's why it shows up that way. Usually starts in the hands. It's asymmetric. It occurs in steps. And then your nerve conduction testing kind of shows nerves that have been picked off. Like you can imagine, I picked off your median nerve, then your ulnar nerve, and so on and so forth. The spinal fluid is usually normal because it's in the peripheral nerves. It's not at the roots. And it can be treated with prednisone or IVIG. There's another condition which is really rare, but I'm just going to bring it up, called sensory CIDP, which is the one condition where you present with numb feet, like the boring neuropathy. Yet, when we do nerve conduction studies, it shows this massive problem with the covering of your nerves, the myelin, and it's an autoimmune disease, and it can respond to prednisone or IVIG. This disease is incredibly rare, but here's the problem. It's the one that everybody gets mixed up with and causes all the dilemma with the insurance companies. So you come in my office with numb feet, I do nerve conduction studies, they're a little off. You probably just have an idiopathic neuropathy. But some doctors are going to go, I think this is CIDP, those nerve conductions are a little off, and they want to give IVIG to the patient. And since there's so many patients who come in with numb feet, a large majority of patients who get IVIG really might not have immune disease, so you have to have a way to manage that. So this disease just gets everybody in trouble and is at the source of the problem, even though it's incredibly rare. And multifocal motor neuropathy is a totally different clinical presentation where people pick off nerves just like Mad Sam, but it's only in motor nerves. So that's what starts making neuropathy so interesting and confusing at the same time, is that somehow when your body develops an autoimmune response, it's like really good at just picking off individual types of nerves. So it could just get motor nerves, or just get sensory nerves, or just get your roots, or just get your nerves out, down by the periphery. So anything can happen, and you can see almost every presentation sooner or later. So it can actually get really hard. And this is a beautiful example of a nerve conduction test, which is what we're looking for. So here you have I'm shocking somebody at the wrist and recording over their hand. And I get a beautiful response in the median nerve, which just looks like a blip that then the line flattens out. But if you look at B, now I'm shocking the exact same nerve at the elbow. So that signal has to get from the elbow to the muscle in the hand. And I'm recording the muscle. And what's happened this time is that signal's gotten all dispersed as it's trying to make it down the hand. So this is an example of somebody who's got blocked conduction between the elbow and the hand, but not between the wrist and the hand. So you know it's somewhere between the wrist and the elbow where the block is. And then the other example is like even a better example of conduction block, where a big chunk of the signal just completely drops itself out. It can't even get through. So somebody like this is going to have weakness in the median nerve territory more often than not. So again, there's no simple test with this. These tests give hints. It's like really uncommon that you see such a good example like I just showed you. So we start looking at like all these different things, nerve conduction, spinal fluid, rarely a biopsy, and blood tests to look for other diseases. And then we try to make a conclusion logically about what a patient has. It's not the easiest thing in the world. And here's kind of a fun slide, but one of the problems we have is like, if you think about it, because I just told you so many different ways tests could come out and people could present, that you end up getting thousands of different clinical presentations, but we only have like 5 words for these 1,000 clinical presentations. And I have a great story, which I could tell you in like 4 minutes, because I think I'm going to run out of time, but I once had a call where I had a patient who was really, really sick. It was a young girl and a different disease totally. But I got onto a phone call. The parent was like, do you mind talking with our friend? They were professors at Berkeley. I was like, sure. They're like, just talk to our friend. We don't want to talk about our daughter. It's too painful. Can you just talk to our friend? So I talked to the guy for like 2 hours. He's like an Israeli, really smart guy. Got totally off into these weird topics. And he's like, after the call, I was like, that guy's name sounds familiar. And I went on the internet and looked him up. And he had just won the Nobel Prize for economics. I was like, yeah, he was, in fact, like a super smart guy. So then I read his book. His name's Daniel Kahneman. Has anybody heard of him? Not one person. That's really sad. So here's the thing. The guy uses this quote, which I think is brilliant. He says, if somebody asks you a question that you can't answer, what you do is just answer an easier question. So you're actually not answering the person's question. You're just saying something. So politicians do this all the time, as do humans, but it's an art and it's wrong. And it's not really what you want to get from your doctor, where they're going to answer an easier question. So since we're in this field that doesn't have enough names, this is where all the conflict starts. It's because people are doing exactly what Daniel Kahneman says people do, because they don't think when they hear a question, they just answer it. So why don't we know? So here's the story. So two neurologists are walking in a farm area. They're in a farm. And they're like, they're neurologists, so they're oblivious, weird people. That's a guarantee. And they're walking through this farm area, and one neurologist is looking at an animal, and he turns to the other animal, and he says, is that a dog or a cat, right? And here's what they're looking at. And the other neurologist goes, it's a dog. And they continue walking. And that's the joke. That's the end of it, because they were wrong. But the reason that they were wrong is not really because because they're not smart people. They're very smart people. They made it through med school, but they didn't think. They just answered the question instead of thinking about it. So a cow technically is much closer to a dog than a cat. If you didn't know a cow existed, you would answer that question as a dog, and nobody would ever... is there anybody in this room who thinks a cow is closer to a cat than a dog? Is there anybody in the room who thinks a cow is closer to a dog than a cat? Right, I can't believe you guys actually answered that question, but the thing is this, though. It is closer to a dog, and it's legitimate if you don't know to think about these things. And that's exactly what's happening with a lot of patients. You're going into a doctor's office, and they don't 100% know what they're looking at, and they're telling you the next closest thing. They're answering technically a different question than the one you're answering them. And this stuff matters because it's all over the place. We look when I was reviewing insurance cases, you get a nerve conduction study that's just off of normal. And you don't really know, is this CIDP or is it just a little bit off of normal? And it's really a normal test with a little bit of variation. So you get these readings like demyelinative polyneuropathy, clue that the patient needs IVIG, and then the insurance company says, that thing was really normal, you can't get IVIG. So these are the kind of dilemmas. You get spinal fluid of 83 in somebody who's 83 years old. Who knows if this is abnormal? So you get into it. So the last thing I'm going to talk about before we finish is and this is just really for fun, but there are a lot of weird cases out there, and it's not an easy field, and it's kind of where the dilemma is. And I just hope you all have a good diagnosis. So the last story is about another neurologist who's sort of an anal compulsive researcher who comes out of his front door every morning and is really obsessed with the weather. And the guy says, I'm just going to every morning record two questions, is my driveway wet or dry, and is my lawn wet or dry? And if from those two questions, I will be able to make a diagnosis about what happened the night before as far as the weather is concerned. So the guy's really smart. He wants to publish this in the New England Journal of Medicine someday. He's really a great researcher. And he knows that if the driveway's wet and the lawn's wet, that it rained. And he knows that if the lawn's wet and the driveway's wet, and the driveway's dry, the sprinklers are on. Great diagnoses. And he knows if everything's dry that nothing happened. So every day he records his observations, and he's super content. He's about to write up his paper. Then all of a sudden one day he goes out and he sees this weird observation, the driveway's wet and the lawn's dry, and he can't figure out what's going on. What's necessary here, I would argue, is to begin to think out of the box or refer to somebody else who has the answer. And the answer here was that somebody watched the car before he got up. But I think what too many people do is they try to group it into something they already know and call it a rainstorm variant, which is not technically the right answer to the problem. So again, it just requires a real sense of being able to talk and discuss and think. And I think that is, as best as I could tell you, the way that an advanced neurologist would think about these diseases. They're really hard. And I'll just see again, there's many other neuropathies that we have to think about, and not everything's a neuropathy, and it's a hard diagnosis. And I alluded to how hard even B12 deficiency is to diagnose. Diabetes, you're a little diabetic. Is that why you have a neuropathy or not? Not easy to know. Low back problems sneak in there from time to time, where people get weird presentations. Sometimes your feet just hurt, and it's not a neuropathy, and you have to manage your feet, chemo, other weird conditions. So again, it requires a lot of thought. So the diagnosis is usually pretty easy, but there's many possibilities and weird presentations. Neuropathy is actually rarely treatable, but when it is, you're probably going to end up in a support group like this, and you're probably on IVIG, and there may be some controversy with your diagnosis. But my advice to you as patients is just make sure you know what you have. It's really important. So thanks, and I probably have no time for questions since I have 9 seconds left according to this.